This patient was referred to us from another hospital who came to us in septic shock. Of note is that the GCS was low of 7/15. So when it goes through how she was resuscitated, what are the things you're supposed to do when you receive a patient who is in septic shock? All right.
Okay, thank you, Doc. Thank you.
Very good. We
Thank you.
That one of the commonest cause of maternal death in our country, the leading one is sepsis. Sepsis remains the leading cause, and indeed, it's non-pregnancy related one, sepsis. Just like in our case, so the non-related sepsis to pregnancy. So that will be our discussion today. Dr. Mhlabi, tell the student, why was this patient intubated?
Okay, thank you, Dr. Mhlabi. So firstly, on arrival, the GCS was 7/50. That was one of the indications for intubation.
Very good. Why must those who got low GS be intubated?
You want to make sure that they've got cardiorespiratory support. We know that especially if they've got a low GCS of
cardiorespiratory support. Is it related to GCS, Dr. Mhlabi? Dr. Zawa, I want to add something to that. Yeah. Perhaps before we go to hemodynamics. Absolutely. Yeah. The issue of vomiting, the person you want to prevent, just to protect the airway. In case of vomit, she's going to aspirate, and we know the outcomes of pneumonitis. Very bad outcomes, isn't it? Already she's sick. She's got one septic shock. If she aspirates, you are sure she's going to demise. All right. From aspiration pneumonitis. Yeah, you want to add something, Kalala?
Yes, I think when the patient is unconscious, the tongue will obstruct the airway because it's going to fall down and then obstruct the airway. That's why the airway must remain patent by intubating the patient.
Absolutely, doctor. All right. Now we come to golden hour. What are the things that I'm supposed to do? The BP is 40/20. Very low. How can you raise that up for the students? We'd like to also comment, Doctor, how will you complete this blood pressure?
When the BP is that low, we can use, I just forgot the collective name of the medication, but I use such things like phenylephrine. That's the collective.
Okay, guys, do not check. Next to her.
Yes.
Absolutely. Very good. She has mentioned something like phenylephrine. Those are inotropes. Those are inotropes. That's one option. Doctor, from your side, anything you'd like to add? Perhaps before you give inotropes, is there anything that you'd like to give that can raise your blood pressure? She's hypotensive, isn't it? Yes. That BP is telling you I'm not perfusing the vital structures. All right. In fact, which vital structures are very important at this point?
Yes. So you're talking about the brain?
The brain, yes. Very important. Don't perfuse the brain dies, that person will have an ischemic brain. All right, so you need to make sure that blood pressure goes up. Two, Dr. Mhlabi?
The renal kidneys.
The kidneys, isn't it? If you don't perfuse the kidneys, what will happen to the kidneys?
So you'll have a tubular necrosis or acute kidney.
Absolutely. The first step is AKI. But if it goes on to have acute tubular necrosis, those kidneys are dead. You're going to need a renal transplant. No matter how much dialysis won't come out, isn't it? However, if you treat AKI, which is the first step, it's just an ischemia. Before the infarction happens, you need to get this person out of this problem, all right? Before you give inotrope, doctor, which is phenylephrine, one of them, perhaps, what can you use, Dr. Mamet? Before the inotropes. Before the inotropes, before the inotropes, doctor there who is very far from the mic. Is there anything that can use? Anything except the link. What else can you use? What else can you give? You are in the peripheral, then you're over there. What else can you use? They don't even have anything. What are you supposed to do? You'll give fluids, doctor. Yeah, but don't shake your head. Be certain the doctor is going to give fluids. That's the correct answer, isn't it? You're fourth year. Doesn't matter if you're fourth year. Say with confidence. I'm going to give fluids. All right. Very good. That's the first step of resuscitation. You are going to give fluids. All right. To bring that blood pressure up so it can perfuse our vital organs. All right. Mainly the brain, the kidneys, the heart. All right. So it can continue pumping. If you don't do that, you're going to lose the patient, isn't it? All right. Tell them, Dr. Zawa, quickly, you don't have much time. Which food are you going to give them?
Yeah, so we're gonna give them crystalloids.
Excellent. Crystalloids.
Yes, so
All right. Those are resuscitative fluid. Okay.
most of the patients that are septic are already in metabolic acidosis. You'll want to give them ringas lactate or a plasma light, which is well balanced, and plasma light has backup. So you don't want to give them normal saline because you can have hypothalamic acidosis. So you can worsen the condition.
Wonderful. Are you following that, doctor? It's a balanced solutions. And normal saline is it's not the top, it's not one of them. You know, as much as the crystalloid, normal saline is putting it, it's high in chloride, all right? So you are worried about hypertonic metabolic acidosis, which can worsen the patient's situation. Dr. Mtabi has put it clear already, my patient is in metabolic acidosis. All right. So you're going to give the balanced solutions. One of them easily available, as much as just slightly expensive with few cents compared to normal saline. Ringas lactate, all right, easily available in our institutions. All right, we are privileged to also have Balsol in our institution. We've got Balsol, we've got plasmolite B, those ones that are rich, the high in bicarbonate, which is what we need in this case. You have seen how low is your bicarbonate, isn't it? All right. Very good. What is the advantage of having bicarbonate, Dr. Zava? What does it do on this patient who are metabolic acidosis as the bicarb rises? This patient was resuscitated also given bicarbonate. I want him to mention it that this patient was given bicarb, about 3 or 6 ampoules, or even in theater. Why must we give bicarbonate when we're resuscitating this patient? What is the role?
So bicarb improves the acidosis and helps the patient to also perfuse in the organs that we are talking about, that we are trying to prevent further organ damage, because already this patient, once he's in septic shock, is because septic shock means that patient has already has some end organ dysfunction or on organ damage. So we're trying to prevent further and to try and improve the perfusion. So for those organs that are still working.
Very good. Very good. The bicarb then improves the hemodynamics. All right. Over and above what I said, I don't want to repeat because of time. He is very correct. On top of the third additional point is that it increases the sensitivity of our drugs. The ones that you mentioned, the phenylephrines. What you mentioned, the epinephrine, which is adrenaline, isn't it? The sensitivity of adrenaline is increased when you're giving bicarb. All right, when you're correcting this acidosis. Acidosis worsens that blood pressure, which is over 40 below 20, isn't it? It does get worse when the patient becomes more acidotic. The patient does become vasodilated and decompensate even further. All right. That's why it's so important that we correct that metabolic acidosis with bicarb. All right. That's Dr. Zawa is making other points regarding that. All right. Very good. What else can we do?
Yeah.
How much fluid, Dr. Kalala? We are giving a balanced solutions. Dr. Zawa is mentioning to prefer ringas lactate, plasmolite B. How much are you going to give this patient, Dr. Kalala?
Okay, we can go up to 150 mils per hour depending on the level of what you call dehydration. Up to 150 mils per hour, just to improve the perfusion and also the circulation.
That might not be enough. That might not be enough, Dr. Kalala. It might be very low. Let's ask for help from the
150.
Yeah, it might not be enough. Dr. Makachava, okay. I know it's very hard. You want to answer Dr. I can see. That's fine. You're right. Shows Dr. prepared. Okay. Dr. Makachava, how much food are going to give this patient?
You're going to give them 30 mils per kg in the first 3 hours.
Listen to that, Dr. Kalala. Can you hear the answer? Did you hear the answer? The correct answer?
250 mils in the first 3 hours.
No. Listen carefully. Dr. Makachava, repeat yourself.
Yeah, it's 30 mils per kg in the first 3 hours.
30 mils per kg for the first 3 hours. All right. That's the correct answer.
30 mils per kilo. Okay.
All right. Not 150, not 300. No.
Okay. No.
All right. However, also
okay.
option of boluses. Yes. Also have option of boluses. How much boluses can you give Dr. Makachava? Back to you. Speak louder so that these guys can hear you.
Okay, so with boluses, you can start at 500 mils as a start bolus, and then with increments.
Yeah, 500 mils. Some will give 1,000 mils. Some guys are very aggressive. However, they came up with a formula. Data shows no. There's so much variety. Some will say, no, I'm giving 250. I'm giving 500. I like 500 as well. interestingly, you know. However, when we look at the data says please use 5 mils per kg. All right, take the 5 mils per kg. Fluid bolus. All right, fluid bolus. Of course, those who are cardiac. It also allows you to test those who are cardiac patients, renal patients. You know, give that bolus and observe is there good urine output. Is the BP improving? Remember, fluids can also worsen the condition of the patient, isn't it? Someone who's already fluid overloaded, but hypotensive, you know, a septic patient can be like that, isn't it? All right, so we need to be careful of that. All right, so you give that fluid bolus, that's an option, but however, it's your correct thing. That's 30 mils per kg for the first 3 hours, guys. All right, good fluid. Anything you have to give for this person who's septic on this golden hour, food is covered. Do not give volumen, isn't it? Do not give volumen. Where's our concept? Behind you, is he there? Oh, he just arrived. Gentlemen, why must you give volumen on this person who's septic shock? It decreases the infection. Not really. Doctor, can you assist? Are you going to give volumen? No. Why not? Fair enough. Dr. Magachawa, or you want to try? Yes. Dr. Mawa is giving you the benefit of the doubt. I'm worried of time.
It has potassium.
Dr. Zawa, I need to move. Dr. Zawa, you want to assist her?
Yeah, so it will worsen the renal impairment on the patient, so it will cause.
All right. We found that when we give volume, septic shock, not hemorrhagic shock, septic shock, we found the rate of AKI, acute kidney injuries, is increased. All right. So we don't give AKI, we don't give volume. All right. The pathophysiology, you can go through it. Doctor, I think one of the time, isn't it? With what it contains, those solids, what they do. All right. But for now, we just end there. We don't give volume. We're going to give those balanced solutions, as Dr. Zaba has mentioned. Anything we want to give in this golden hour, fluid is number 1 before the adrenaline. All right. If does not respond to if your BP remains low, meaning that you have given your fluids, all right, as you said, but don't wait for 3 hours. All right. In an hour, you assess, is this BP coming up? You know, still not coming up, give a bolus of fluid, all right? Run it fast, still not responding, you need to go for your, you need to add your inotrope and vasopressors, all right? Inotrope and vasopressors, these drugs, they do both these functions, all right? You need to add your vasopressors, don't wait for too long. Even hemorrhagic shock, please don't wait for too long by giving blood while BPs are low. Please, these are temporal things, eh? Vasopressors and allotropes are temporal until the problem is sorted out. All right. Using the allotropes, quickly, Dr. which is allotropes in septic shock.
Yeah, in septic shock. So the first line.
In order of preference, yes.
Yes, the first line is the norepinephrine. Good. In septic shock, the dosage is 0.1 microgram per kg per minute. Then the second line is the vasopressin. The third is epinephrine. In our case, we have adrenaline in most of our district hospital. So that will be the drug of choice in those settings.
Absolutely. Yeah. I like the fact that the availability as well contribute. You don't have no adrenaline, which is our first choice. You use adrenaline, as mentioned the doctor, epinephrine. All right. But no adrenaline is the number 1. Number 2 is adrenaline. All right. Number 2 is vasopressin. But we don't have vasopressin in our setting. The BP still remain low, meaning that your MET is below 65. This low means your MET is below 65. Your target is of giving fluid, you want the MET to rise to 65. All right, 65 and above. If it remains below that, you titrate, increase your dosage of noradrenaline, increase your vasopressin, add your noradrenaline until you get the BP of 65. Here you are sure you are safely perfusing your organs. The important one being the brain, kidneys, as I mentioned, the heart as well, isn't it? All right. So you give inotropes. All right, fluid on board, inotropes on board. Anything in septic shock, Dr. Zaba, in this golden hour that you must do?
Yeah, you must not also forget antibiotics. We're talking about sepsis already.
Excellent. Antibiotics. All right. You must give antibiotics. What must you do, Dr. Zaba, before you give antibiotics?
What must we do before we give antibiotics? Because we said the principle is to give fluid, inotrope antibiotics.
Yes.
Management of shock, and then look for and remove the source of infection. So those are the four principles I remember.
Correct, Doctor Kalala. We're coming there, not yet there, isn't it? Surgery, we're going to come to surgery and the timing of the surgery on this patient. All right.
Okay.
Sepsis control, principle. So Zaba's going to give antibiotics. We're saying, what is the most important thing that you must do before giving antibiotics? Student, doctor.
We need to check the kidney function.
No, I'm asking the students now.
We must do the blood test to see the kidney function.
Before do blood culture. Before I'm doing that.
We need to do the blood and the blood culture.
Kalala is saying, all right? Dr. Kalala is saying, before you give antibiotics, give your blood culture.
Blood culture.
Blood culture results.
Yes.
Before. You need to give antibiotics. You need to do blood culture before giving antibiotics. You need to do a blood culture.
Oh, okay.
Blood culture, all right? To the microbiome so that they can. Because this can give false negative results. While the patient's got money, the patient's got bacteria in the body. That antibiotic just wash it off, giving you false results, and then you are going to taper down antibiotic, there's nothing on culture, isn't it? All right, so do a blood culture, please. This is a very important thing that you must do. Quick, it doesn't take long, isn't it? All right, get bottles. But in the absence of bottles, doesn't mean that you must give antibiotics. You may have to give. Because I'm not going to give antibiotics. No. The doctors inside said, no, don't give because you have to do a culture first. If there are no bottles for culture, please give. In that 1 hour, you don't have time down. All right. Sometimes in our setting, we don't have bottles. All right, for the culture. If they're not there, give antibiotics. All right. But when you think the bottles, take the bloods. All right. Keep them there and then send them for blood cultures. All right. Both anaerobes and aerobes, isn't it, Dr. Zara?
Yes.
Very good. How much must you put in those bottles? We have realized we've got negative results. Doctors put just small mils. Minimum, Dr. Magachava?
You need 2 mils.
How much?
2 mils.
2 mils. 2 mils maybe in pediatrics. Dr. Zawa?
Yeah, we start from 5 mils each bottles.
Yeah. At least, Doctor, 5 mils each. 5 mils, all right. 5 mils. You take 10 mils, 5 mils in each. 5 mils in each. We have realized, Dr. Magachava, 1 mils, the interns. I don't know the interns here. Are they here? They just put 1 mil. It's really, please let's put at least 5 mils, Dr. Magachawa. Maybe pediatric bottles are made for smaller babies, they want to more blood babies. But for us, we need 5 mils for us to grow something in those cultures. All right. When we culture them. All right. We do grain stain, they do a lot of things there. So it can flex for you as soon as possible, and then you get the results. All right. Good. Dr. Jawad mentioned antibiotics. I mean, it's not clear, isn't it? What's antibiotics? What must you add to that? It's a broad spectrum. That's the important thing about it. All right, don't give amoxicillin when doctors also must give antibiotics. No, it must be a broad spectrum covering both gram-negative and gram-positive. All right. So, which antibiotics are you going to give, Dr. Mtagu?
So, preferably, you give the beta-lactamase inhibitors. This will include things like augmentin, or depending on the source of the sepsis. If it's a gastrointestinal sepsis, I recommend that you can start with your tazocine, which is piperacillin and tazobactam combined. It's a beta-lactamase inhibitor as well. Ampicillin, it's a broad spectrum antibiotic as well. You can consider that, especially in those districts. They might not have these drugs that we're talking about.
Remember what you want to cover? Anaerobes. Yes.
And
what about anaerobes,
yes.
aerobes, gram-negative, gram-positive, and anaerobes?
For anaerobes, you need to give flagyl or metronidazole.
You don't have that cover, isn't it?
Yes.
Augmentin gives you that. Yes. All right.
Yes.
But as he's saying, when you decide on which broad antibiotic to give, you look at what the source of the sepsis. Where is it? Is it intra-abdominally? Is it in the brain? Is it in the chest? All right. Of note again, what you must also look at is important. Previous antibiotic use. Previous antibiotic use. If you're augmenting at the peripheral hospital, you are not going to augmenting again. All right. So nerves are already. You can see it's already an antibiotic. You need to up to something very strong, isn't it? So I think the word Dr. Mabawa was for gynaecological sepsis, I need to give her something strong, all right? The septic shock as well, someone's septic shock, you need something which you want to make sure cover everything. You don't want to lose that patient. You know, to resistance to this antibiotic given. All right. So those are some of the things. Of course, some patients are allergic to penicillin. You need to make sure you've got that history on your history checking. That's why when we are seeing patients first years, you need to ask, are you allergic to anything? All right. Because when they come to us, they're already unconscious. I'm going to give her a penicillin. All right. So you had a chance to talk to her when she arrived at your setting to the interns. Don't forget to ask that question. Are you allergic to the drugs? All right. So when they come to us unconscious, we're able to manage them further, okay? And correct without worsening the condition of the patient. All right. Dr. Asha, want to add anything on the antibiotics? I think Dr. Asha, this is one of the antibiotics in our obs and gynae units. So that's, she said, Dr. Mintabi, you are correct. That's where we should be looking at, isn't it? All right, and of course, considering our setting. Yes. All right, but when give them flights, when you come to us, we'll give you something broader, isn't it? Yes. Okay, our first choice, community acquired as well. You know, to augment it. Someone's been out of hospital, think of a hospital acquired infection. Those are the bugs that are affecting the patient are resistant to augmenting. All right, data is shown. They were going for our carbapenems, meropenem, you know, just like our patient when she arrived, which antibiotic was given to this patient?
She was given tazocine in casualty.
She was given tazocine. Excellent. What is tazocine, Dr. Zawa? We've got students that don't know what is tazocine.
Yeah, it's a mixture of piperacillin and beta-lactamase. Tazobactam.
Very good. Tazobactam and piperacillin. All right, that's what the combination is, and it's considered good spectrum cover. Our both anaerobes as well are covered by that, including gram-negative positives. All right, very good. So the antibiotics, you've covered that. You have given her fluids. You are giving her inotropes, getting the blood pressure up, and so that back up as if the BP remains very low. Anything can give in terms of improving she remains hypertensive, Dr. Zara. BPs remain 60-40, MEP of 45. What else can we add to this patient so that this blood pressure can go up?
So if you remember correctly, we need calcium also in our body for these muscle contractions. So the heart to help, we need also calcium gluconate.
Calcium gluconate, isn't it? Very good. And calcium gluconate also boosts with your cardiac contractility. All right. So BP can temporarily go up in order to perfuse the vital organs. All right. And indeed, they tend to be the calcium tends to be very low. I wonder how much was the calcium in our case, Dr. Mtali. I picked it up that did not read the blood gas correctly. If you tell us about the sodium, just pick up the only thing.
It was not visible. That's
The calcium was how much was the lactate?
The lactate was 3.8.
3.8.
Yeah.
All right. Very good. And then with that low bicarb.
Yes.
Okay. So calcium here was not recorded, but most of the time it's low. You have to give calcium. With just like when you're giving bicarb, the sensitivity of this isotope is decreased. All right. Give calcium gluconate. Anything in septic shock we have to give, Dr. Makachava?
I would like to give steroids.
Very good. It's very good. Dr. Zaba, don't forget steroids. All right. So the mainstays. All right. Steroids must be on board. Which steroids are going to give this patient in order to improve these blood pressures?
So we'll give them hydrocortisone. You start at 100 milligram IV stat.
100 IV stat of hydrocortisone. Perhaps Dr. Zaba, correct that quickly? We understand?
Yeah, we'll give 200 milligram IVI stat, and then we can continue with 100 milligram 8 hours.
Very good. Doctor, don't forget, these are guidelines, Dr. Makachawa. Say there's people online who are listening to us, so they might take that 100. You know, it's inadequate. 200, that's what I was saying. IV stat followed by 100 milligrams IV every 6 hours. All right. That's what we'll be giving the patient in order to improve this hemodynamics of this patient. All right. And then we go on to add vitamin C when they come to ICU and our thiamines, all right, in order to improve this patient's outcomes. All right.
How does hydrocortisone helps in improving the outcome?
So this patient comes with overwhelming sepsis with inflammatory. So hydrocortisone.
With inflammatory?
Yeah, in the inflammatory shock, sort of like they're having
Shock.
not really inflammatory shock, but they're having inflammation. So hydrocortisone helps with the inflammation. So
So in septic shock, there is an excessive, as you were saying, that inflammatory response, cytokines and all that too much, and they are causing damage to the endothelium. So by reducing that inflammatory response, you are reducing the damage to the endothelium. That's how it's going to be.
Very good. Dr. Adam also reminding us to have also this story behind. What is the answer comes from what is this septic shock? Dr. Muyela, you want to tell us the students, the fourth years who are here, the different what is septic shock? What is sepsis? According to the latest guidelines of sepsis guidelines of 2023. Even the previous one, I think the definition is made the same.
Septic shock as well is a systemic inflammatory response leading to multi-organ system failure.
So what's sepsis then?
Sepsis, I think, is
You can see it's incorrect.
yeah, it's incorrect.
Yeah, think again, take your time. Don't be afraid. We're very more informal. People are just gathering around the table, you know. Dr. Mwawa, you know, the camera, so don't worry. You can relax. Okay, I think let's take it back to Makachava. You want to the difference between sepsis and septic shock, or what we call severe sepsis. Severe, what's SIRS, severe sepsis, and septic shock. All right, but now we later septic shock is severe sepsis. This is severe sepsis, that's sepsis, and we're septic shock. Severe sepsis, let's use those ones for now.
I think here the difference is that in septic shock, then there is failure of compensation. There's failure of the bodies to be able to compensate both as severe as.
You are answering the question, doctor. It's a written. This question I'm asking you was a written question on the part 2 before the all these exams. The difference. I don't know how you write. You're taking time.
Okay.
Specific issues in medicine. You know what is it? Define sepsis. Define septic shock.
So it's an inflammatory response secondary to either bacterial or viral infection with the resultant multi-organ dysfunction. So now with sepsis, they still when they are not yet in shock, they are still able to compensate. And yeah, I think that
Dr. Kalala, I want to assist. She's coming all right. She's taking the time. I think if it was an oral doctor, we're going to lose time. You know, we're just going to see them look at you. Dr. Kalala?
Septic shock. Yes, septic shock is when the organs get affected by the infection and then they start to fail. So we get into septic shock. So the organs are unable to perfuse because the pressure in the system, I mean, the resistance is going to drop because of the overwhelming.
Sepsis, Dr. Kalala?
Sepsis is just the reaction of the body toward infection. So is when the body try to mount the defense toward infection by producing the antibodies, and also there's a release of inflammatory markers like what you call tumor necrosis factors.
Yeah,
you have
you're taking time. You can see you're losing marks. You are delaying. You have specific issues, and then what will be? I'll put it forward to you. What then will be SIRS? Systematic inflammatory response syndrome. What is systematic inflammatory response syndrome? This is a spectrum. This thing. You start from SIRS.
SIRS is a spectrum where you have organ failure, blood pressure that is dropping. Sorry?
I need to go back and you need to read again. I think this will left to Mankwe, you are losing touch with us. And you can't be having SRS now and organ failures. No. It can't be like that, Dr. Kalala. Please. You are with us. You are losing touch with us. Let me ask the Dr. Zaba come in and quickly rescue the team, rescue Dr. Muyela and Dr. Makachab.
Yeah, so it is a systemic inflammatory response secondary to infection linked to multi-organ dysfunction or failure. So with septic shock is
So
now
which one?
it's a sepsis.
This is sepsis. What
Yes.
do you call severe sepsis?
Yes.
Listen to that, Dr. Magachawa. Very correctly put. All right.
So when it comes to septic shock,
Let's start again. Tell the students I want you to follow sepsis or what they call severe sepsis.
yeah,
Sepsis.
it will be systemic inflammatory response secondary to infection leading to multi-organ dysfunction.
Yeah. So we just say it's dysregulated.
Yeah.
All right. This is abnormal response. That part must come into the every time it must be there. This is dysregulated, response, isn't it? To systemic response to infection. It can be fungal, doctor. It's not only to bacteria and viral. Okay, it will be fungal. Also, that's an infection. That's enough. Or you don't everything. Continue.
Yeah. So when septic shock will be when now there is a failure to regain your BPs, and now there is introduction of inotropes. So once you introduce inotropes, it becomes septic shock. Or if you have lactate of more than 2, then it becomes septic shock.
But
Let I add.
in a
Very good.
hypovolemic shock also, there can be lacrits can be high, so it's not done. So when your hypotension is not responding to fluid resuscitation, and there is a need for the iron drops, right?
Good.
Yeah,
So it's organ dysfunction with the need for inotropes to maintain blood pressures.
Yes.
All right, and it says all, and that's correct. It says all lactate above 2, but now I think we're put it to 4 without. Yeah, some say 4, above 4. All right, those ones who argue for 2, they say perhaps 2 might be better because we tend to pick up cases very early. All right, but we say 4 and above lactate, and it shows that Zawa has read the guidelines. Well done, Dr. Zawa. Any questions? Come again? Yes, yes, that you have given fluids, the lactate has remained as well, above 4. All right. So that's the definition of that's the difference. That's the way we have passed the station. Okay, well done. Dr. Mwawa, this guy, you can see when you're in the middle of a station, it also makes you to read around research. Septic shock. So it's reading around it and getting to deal with these cases, and it will make a difference out there in our communities. All right.
Dr. Mhlari, because of time, you've been talking about the unit of resuscitation, and I think it's a brilliant idea. Can you just tell the team, or especially those who are from the peripheral hospital, how does that work, and why was it like that, and how do you find it working at the moment? Because that's an excellent idea, which I think all hospitals should actually emulate what you're doing.
Absolutely. So this is an obstetric response to patients who are in septic shock. It's also a gynae response to patients who are in septic shock, depending with sepsis. So to assist with the resuscitation of these patients, to assist doctors on how to resuscitate these patients. All right. This came up about because we saw the need to say, look, we can't be alone on this. Guys said, look, resuscitation, we need more members to improve outcome of these patients. We need to have more members, don't have to wait for Dr. Mhlari to be there to say how to intubate, how to give inotropes, the dosages. Sometimes the consultant will be calling me for those dosages and I'm not available. If Zawa is there, knows the dosages, Zawa is able to then talk to the doctor, say the dosage you're going to give. This is the protocol that we use. This is the first choices, Doctor. You start with adrenaline. How much adrenaline we're going to give. So we want to be involved. So our guys in the resuscitation response team, they are aware of these dosages. All right, they are aware, and we use them now and then in ICU. And as someone is aware of this, and then they're reading around it, they're able to quickly respond and advise doctors on the ground. And also the guys who are in the periphery, when they call, we're able to advise them, say, okay, at this point, this is how we're supposed to use adrenaline. Not 1 amp in 200 mils. No. How much must you put, Dr. Zawa? How much must you put in 200 mils of 20? All right, you must put 20 so that you can correctly give the correct dose. All right, 0.05 to 1 micrograms per kg per minute. That's the dose of adrenaline. So the guys who are on the response team, the resuscitation team, they're aware of these dosages. All right, they're reading around, improving ourselves and aiming to improve the outcome of patients. So that's why we saw the need, Dr. Mwawa, So let's have a group of response team to say, let's come together and see how we can assist in managing our patients to improve the outcomes of our patients.
That's marvelous. Because of time, it's 8:07 now. We are out of time. Can we give Dr. Mhlabi the last words, and then Dr. Mhlari, and then we close.
Okay, from me, to add, Dr. Mhlari, is the issue around oxygenation. Oxygen is very, very important in these patients. We aim for saturation of 94 and above, especially for the guys in the periphery. Also, as we said, the role of intubation. The other thing is the thromboprophylaxis. I think they can give, or they can start taking from the local hospitals. That has also been documented to also assist in patients that are in septic shock as well. I think.
Excellent, very good. I wanted to just say before they leave, those guys, when you are supposed to intubate this patient, because this patient they come to us already intubated, these ones who are in shock, the drugs that we are going to use, try to use as minimum as possible. Try to use as minimum possible. You don't have to drop your blood pressure even further. The BP is 40-20. So you can see if I'm going to give a full dose of propofol, I'll kill the patient. Propofol on itself, it will be contraindicated in this patient. It's going to kill the patients. The patient arrested, and you can see in our case, the patient arrested. So when I use something that's hemodynamically friendly, isn't it? Something like ketamine, something like domicam, very friendly, but at the lower dose, isn't it? You don't want to give rocuronium. She's already out. The DDS is 8. It's 7. She's not responsive. If I would actually intubate without giving any drugs, this patient, all right? So if you're uncomfortable, you want to give scoline, you want to give rocuronium, give as little as possible. I would advise scoline, it's much better. However, scoline must first check for potassium. Dr. Zawa, potassium must be normal before giving scoline to avoid rhabdomyolysis, all right, related to drug-induced. So give scoline, low dose of domicam, please, at most 10 milligrams, at most. You can do 7.5, this person is not fighting you, she's unconscious, she's not responding. Just put a tube inside there. And I will advise the smaller the better. You don't want to be battling as well. 7 should be fine for the guys in the periphery. For us, we can go for 8, when they come to ICU, don't worry, we'll change the tube to the correct tube, all right? But for you, even if you have a 6.5, you don't need to bed patients every day, so it's going to be difficult. Put a 6.5, as long as you get oxygen in that patient and secure the airway. 6.5, 7 is enough. You go for 7.5, 8, you might have difficulties. All right. Put the smallest that you can, secure the airway. We will take care of it when the patient arrives this side. So that will be the advice, and avoid drugs. She's already, if you give her rocuronium, I'm telling you, she's going to demise. So please, let's watch for that as well. We just wanted to add those remarks before we leave the opportunity to the guys in the periphery, and also to the guys, our doctors here, our registrars, when they call consultants, they call Boshuman, they're intubating. Those are things that you must know when intubating patients with septic shock.
Thank you, Dr. Mhlari. Because we normally have 50 people log in today, they were struggling. We will put this online. This is a recorded session, and it actually was done brilliantly. So for the people who didn't manage to log in, and even if you logged in but logged in a little bit late, this will be recorded, and then I'll share the link on where you access it. Thank you so much for the team on the peripheral hospital. We are doing it again next week. We will give you the topic and the professor or the coordinator who's going to be coordinating the session. So thank you all. Goodbye. Can we say goodbye to everyone? The students to just say goodbye. Yeah.
Bye, Dr. Mwawa and the team.
Oh, bye-bye, doctor.